Good afternoon. My name is Mark Pegram. I'm a medical oncologist at the Stanford University in Palo Alto, California. We are here at the 2025 San Antonio Breast Cancer Symposium, and we'd like to have a chat this afternoon, Dr. Yan and I, with some of the late-breaking data presented here at the meeting, and also review some of the exciting news from not only ESMO, but also ASCO last year. And so we're going to focus today on the treatment of first-line HER2-positive metastatic breast cancer. But first, I'd like to introduce my colleague from Seattle. Dr. Yan, please introduce yourself.
Yeah, my name is Fengting Yan. I'm a breast oncologist, and I practice in Swedish Cancer Institute in Seattle. I have been there for 10 plus years.
Well, thank you for taking time out of your busy schedule here at San Antonio to join us today. I'd like to begin with the current paradigm and the long-standing treatment that we've been using for first-line HER2-positive metastatic disease, which is the CLEOPATRA regimen. We've been using that for more than 10 years. What's your take on that? Is the reign of CLEOPATRA threatened with the new news from ASCO this year?
Yeah, absolutely. Of course, we have been using THP for 13 years from 2012. And of course, it's not for everybody. And, I do have patients with neuropathy, and I do have patients really with aggressive disease. And there are patients who absolutely do not want to lose the hair. Sure. So we need options. And I cannot believe we only have one option for 13 years. I'm very excited we have different options now.
That's great. Can I ask you, for the hormone receptor positive, HER2 positive patients in the first line who get a CLEOPATRA-like regimen, were you layering in anti-estrogens during the maintenance phase with the dual antibodies after the taxane routinely on everybody?
Yeah, routinely. Yeah. We do know that there is crosstalk between the ER and the HER2 pathway. Right. It makes a lot of sense to incorporate the anti-hormone therapy earlier in the game. Right.
And last year at San Antonio, we saw a late-breaking abstract presentation of the PATINA trial, which was an induction with a CLEOPATRA taxane and dual antibody regimen, followed by a maintenance phase that incorporates not only anti-estrogen but CDK4/6 inhibition. What's your take on that?
Oh, it was exciting. It was practicing changing, and in my opinion, when it's triple positive, those patients should be offered the PATINA regimen. It's not widely accepted by every single oncologist yet, but specifically for those patients, triple positive, high-risk disease, and they should be offered.
Are you able to do that now? Do you have any trouble with insurance authorization with the PATINA regimens?
No, I actually have been lucky, and as a matter of fact, the day of San Antonio last year, I actually, right before that, I saw a patient, and she was on PATINA since then.
Wow, that's really exciting. Now, I understand PATINA has yet to be published in a peer-reviewed format, and I don't think the guidelines committees or the FDA has weighed in on that regimen. How do your colleagues feel about that? I know they're probably early adopters, both academic and in the community, that do things early, literally on Monday after an exciting late-breaking presentation like that. They had such extraordinary results. But others are more measured. They wait for the peer review, wait for the guidelines and the regulators to weigh in. Where do you sit in that spectrum? And how about your colleagues? Do they share your enthusiasm with early adoption?
Of course, I'm the early adopters, and I actually run quite a few clinical trials regarding the crosstalk between the ER and HER2 pathway. I'm a strong believer that there's two pathway crosstalk, and we should target both rather than just one. Of course, not all the colleagues are the early adopters as me, and there are hesitancies too. I got that in the way there are some patients that can be disease-free NED for 10, 20 years without the CDK4/6 inhibitor. It does add on toxicity. So the question would be, who is going to benefit the most, and make sure we're not over-treating the patients with unnecessary toxicity.
Makes sense. Now, what about DESTINY-Breast09? Can you tell us a little bit about the study design for DB09?
Yeah, for the DB09, I'm very excited again. In a way, this is the first time in the past decade that we are challenging the gold standard first line for HER2 positive metastatic breast cancer. So it's a randomization between the THP and T-DXd. The data looks amazing. And remember back in 2012, when CLEOPATRA was approved, the delta of the PFS was only a matter of 8 months. And now the delta of the PFS is way bigger than that. I'm very excited, and for those populations, they truly need new options, and I cannot believe we have been using exactly the same regimen for over a decade.
That is amazing, isn't it?
Yeah.
So it's long overdue, perhaps, huh?
Yeah.
What's your take on the patient characteristics? Who were these patients in DESTINY-Breast09?
So, you know, in my opinion, truly those patients with more disease burden and with aggressive disease, and when I'm concerned about when the disease progressed after the first line, I might be losing them. Truly, when we switch from first line to second line, and we typically would lose about 20-30 of the patients. And those 20-30% of the patients, I absolutely would favor to give them more effective treatment up front as first line rather than save them more effective treatment later. So those are the typical patients we treat every day, and truly both hormone receptor negative and hormone receptor positive patients were included, and especially for the patients with visceral disease, and I think it makes a lot of sense.
I think about 70% visceral disease, so it's a visceral predominant population in this study. And just over half were steroid receptor positive, I believe. That's interesting. Any other special characteristics of interest in the DB09 population? They had a high representation of Asian patients, I think a little over 40% perhaps in that trial, which is interesting.
Yeah, like all the Destiny clinical trials, Asian is a huge population. I like that in the way it's no longer Caucasian-only clinical trials, and we truly need diversity in the clinical trials. Yeah, it's important.
About 30% had PIK3CA mutations, which was expected. And it was the same in both arms. The groups were well balanced, from my recollection, for all the baseline clinical pathologic demographic characteristics.
I know. So I don't recall any surprising characteristics of the patient population. It's a typical patients we would get into the clinical trial, and it's a typical population I would treat every day.
Right. Now the primary endpoint was PFS, and it was pretty extraordinary. PFS in the experimental arm, I think 40.7 months or something. Have you seen anything like that?
No, this is
unprecedented for
impressive.
First line. Very impressive.
But you know, my bias truly has been, I have been educating my patients and my peers too. Especially when it's metastatic, I would prefer to give the most effective treatment up front, rather than see them later, because we are losing 20-30% of the patient each time when the cancer progressed.
By line.
Exactly. So it's impressive.
That's important.
Yeah.
And you mentioned the delta between the curves. I think it was over 13 months, like 13 and a half
15.8.
months. 15.8. That's really extraordinary.
Amazing I was
data.
Impressed.
Now, what about the clinical response data, the objective response? It was like 85%.
Exactly. Yeah, response rate was higher too. And you know, even in later on setting, and my experience has been when there is a HER2 positive patient, when I have one shot to treat my patient, when I'm about to lose my patient, when I have one shot, T-DXd has been my bet.
And that's the highest response rate I've ever seen for HER2 positive metastatic disease. That's unprecedented.
Yeah, you know, think about those. I do have those patients come to me with liver mets and with brain mets, and they are at the edge of organ failure. When I had one shot to treat them, I'd rather give them the treatment with the highest response rate.
That also reminds me, you mentioned brain metastasis. I think about 6% of the patients in this trial had stable brain metastasis.
Yeah, exactly.
But it was stable only, not active brain metastasis.
Not active.
I believe, in DB09.
Yeah, but you know, my perception about the brain mass totally shift. You know, initially, my stereotype would be T-DXd was a large molecule of ADC. It may not penetrate the blood-brain barrier as well. But you know, after I look at all the data, and actually the data in the brain mets patient are really impressive.
It's really impressive. I would argue that the DESTINY-Breast12 data on T-DXd and HER2 positive brain mets was extraordinary in as much as the intracranial response rate mirrored that of the extracranial response rate, which I've never seen with any agent. And so T-DXd is the single most active agent now against HER2 positive brain metastasis.
Exactly.
More so than the HER2 tucatinib-based regimen.
Yeah, and I do have a patient with active brain mets progressed on the HER2 regimen. They still respond very well to T-DXd. I'm convinced.
That's very interesting and exciting. Now, the response durability was also like over 39 months, or extraordinary result also. So durability, plus high fraction of responders. And then I understand there were about 15% or so that had complete clinical responses, almost double that of the control arm. What's special and what's unique about these exceptional responders who get complete responses?
That question always comes, it's not only the patient, and I start to wonder, can we quote unquote cure them? Especially when they have a durable CR in the metastatic setting. And we all have those exceptional responders that they have been NED for years. And we start to wonder, did we cure them?
Right.
Of course, the long-term perception has been when it's metastatic, we can no longer cure anybody, but with more effective regimen, and I start to wonder, for exceptional responders, would that be the goal in future? Yeah.
A couple other efficacy endpoints were reported at ASCO. PFS2 was significantly prolonged in the experimental arm. Does that mean anything to you? Do you watch PFS2 much in these randomized trials, or is it just kind of an interesting endpoint in passing? What do you think about it? Yeah,
I do look at them, but typically that would not be the primary drivers for me to recommend a regimen and for me to change the practice. It's an interesting endpoint to look at.
Agreed. And then how about the OS data? Was there any signal there numerically? Were you impressed at anything with the OS?
Yeah, so
it was interim,
immature. It was interim, immature, but I will be shocked if there is no OS benefit. I will be shocked.
And sometimes PFS2 can foreshadow an OS signal in some large phase 3 trials, if there's enough statistical power.
Yeah.
Yeah, that's really quite extraordinary. The OS was only about 16% mature at the time of this planned interim for DESTINY-Breast09. So we've talked about all these extraordinary efficacy outcomes in DESTINY-Breast09, which are certainly impressive and would be, a great improvement in clinical care for our patients. But all this comes at a price, doesn't it, in terms of toxicity? What are some of the toxicities of T-DXd plus pertuzumab, I should mention, that come to mind when considering this regimen?
Yeah, so of course, when we talk about T-DXd, the ILD is something we never forget.
Right.
And it is something for me to watch for, to advocate, make sure we don't miss that. Across all the clinical trials, it's about 10%. And all we care is we're giving grade 5 ILD, and that's what we do not want. And also nausea and fatigue is common. Nausea, we are getting so much better. We schedule steroid, we schedule olanzapine, that has been very helpful. But fatigue is often the reason that I had to reduce the dose and I struggle with.
Yeah, cumulative fatigue, in my experience, has also been common, especially after many cycles of T-DXd in the metastatic setting.
Yeah, and alopecia can be a conversation too. In a way, when you think about CLEOPATRA, they all lost hair from taxane, but later on when they put on maintenance, the hair would grow back. Even the grade 2 alopecia, in my hands, it has been around 8–10%. It's not high, but that could be a big deal for some patients.
I saw an abstract, I believe it was at ASCO last year, suggesting that the cold caps are not so effective with T-DXd, as you would expect, because it has such a long half-life compared to a cytotoxic chemotherapy drug, which has a very short half-life, relatively speaking.
Yeah, I did have a few patients who would like to try the cold cap, and some of them actually were successful, some of them were not successful, but again, grade 2 alopecia was only about 10%, so we would not know if it helps or not. But I was disappointed to look at the abstract too, because that 10% typically is the one who cares the most actually about the hair.
Now you mentioned grade 5 ILD, which is obviously the most feared. I understand there were a couple of cases in DESTINY-Breast09, so about 0.5%. How do you talk to your patients about that risk? What's the message we need to know about that?
I truly educate everyone and make sure we don't miss that, and I educate them that upfront that we have about 10% of the chance to have these severe side effects of the ILD, and I teach them if there is symptoms and make sure you call us right away and make sure everyone is educated. I'm so fortunate that I have been using T-DXd quite a bit in the past 6 years, and I have not had any grade 5 yet.
Me too.
Yeah, but I truly think early detection, education, and advocate everything is really important too.
Really important.
So hopefully we will never have to deal with that. But my understanding has been typically grade 5. It's either later recognition or later detection. If we are proactive, and the grade 5 ILD was never the reason for me not to recommend T-DXd.
Okay, interesting. In terms of left ventricular ejection fraction, there was a little bit numerically higher number of depressed ejection fractions in the T-DXd group compared to the control group. So I think it's important that we be mindful that you still have to do LVEF monitoring on T-DXd plus pertuzumab as well.
Yeah, and actually, that's sometimes the reason for me to take the patient, take a break and put them on maintenance regimen until the LVEF recovered and we can re-challenge later. It does happen in about 2-3% of the patient. It does happen.
Now there's been more activity on this more like induction maintenance strategy. Let's talk about that for a minute. Here at San Antonio, we saw the HER2 CLEOPATRA data. What's your take on that? Could you tell us just a little bit about the study design and the top line outcome? Yeah,
HER2 CLEOPATRA, it's interesting in the way that we are looking at tucatinib, and traditionally the hypothesis has been add-on tucatinib, can we prevent the intracranial recurrence? Right. So that's the question from the HER2 CLEOPATRA, and it's a very interesting question we're going to answer.
What patients might you select for a HER2 CLEOPATRA maintenance as opposed to, say, a patina-like maintenance if you're going to do an induction maintenance strategy as opposed to an ADC up front?
I'm more thinking about those patients with the high risk of brain mets, or they already had brain mets.
So the hormone receptor negative group especially? Yeah,
and also it can have higher chance of liver toxicity. So if the patient had baseline liver issues, and I would not
Makes sense.
It is more the hormone receptor negative. I think it makes more sense.
Good. There are other trials of this sort of induction maintenance strategy ongoing. We mentioned that about 30% of patients in DB09 had PIK3CA mutations, and so the ANOVA 122 trial is another example of layering in, a PI3 kinase pathway targeted agent as a maintenance strategy as well with inavolisib. So that might be an interesting outcome when the data become available. It's not yet reported.
It'll be interesting, in the way, especially in the hormone receptor, in the HER2 negative setting, and the pathway has been very effectively targeted, and it'll be very interesting to look at the data.
What are your key takeaways then for the management of first-line HER2 positive metastatic disease, and what are some of the key clinical parameters that help you make the decision between one strategy or another?
Yeah, I'm excited when the DB09 is reported that I can offer a different option to my patients when they came to me for consultation. So for the patients I'm looking at, I might be leaning toward DB09, would be if there is patients with aggressive, quite a bit tumor burden, high risk of brain mets, and at the edge of loss of liver mets, and those are the patients I'm more excited to offer them DB09.
Great. I guess I should mention for completeness that the interim analysis of DB09 that's been presented so far was the T-DXd plus pertuzumab arm.
Yep.
There was a third arm of T-DXd plus placebo. There were insufficient numbers of events in that analysis for it yet to trigger reporting, but that's going to be forthcoming. I'm sure by next year we'll see that data as well. So in the interim, if there's an FDA approval or if there's a NCCN guidance with regard to this regimen so that it would be widely available in terms of insurance authorization considerations, right now it would be the T-DXd plus pertuzumab regimen as the go-to first-line strategy for most patients.
Yeah, exactly. Right. And then we do know that the dual HER2 inhibition is more effective than the single inhibition. So I'm totally fine with that, and that's the data we have. Of course, we are all looking forward to the T-DXd only arm, how that pans out. We are very curious and looking forward to the data.
That'll be interesting.
Yeah.
And finally, I should mention there are some induction maintenance strategies that are ongoing involving T-DXd, like the Demeter trial is 6 cycles of T-DXd followed by a dual antibody maintenance with or without endocrine therapy for the steroid positive patients.
And maybe it's a pertuzumab regimen.
And maybe that's exactly where I was headed next. Do you think that's where we're going to land in the future? We're going to do T-DXd based induction followed by, at least in the hormone receptor positive subset, a patina-like CDK maintenance? Is that doable, do you think?
No, I have been actually trying to advocate for that, and in my opinion, being on T-DXd for 5, 10, 20 years is hard, especially like you mentioned, the fatigue can be accumulative.
Yeah.
So I like the idea of maybe we use induction of T-DXd. I don't know if it's 6 cycles or even longer than that.
Yeah.
So hopefully we'll have more data using clinical biomarkers and MRD to kind of guide us with us, because each patient is different. Some may need shorter induction treatment, some may need longer. This is 21st century, this is 2025, and we need personalized care rather than here you go, everyone got 6 cycles of TJP, and I think that was not individualized care.
Right.
So hopefully we have more biomarkers and MRD to guide with our decision. And my bias would be, I do not want to say it's only 6 cycles, and I think it's a very tailored approach that with X number of T-DXd, when both the patients and the physician are comfortable to start maintenance therapy, perhaps followed by patina regimen or the two-kind approach. And I'm looking at hopefully the patients can be very stable on the first-line treatment for a number of years that we don't even need to consider the second-line therapy.
Very optimistic for that kind of vision for the future, and that may well be where we land one day. Dr. Yan, thank you so much for taking time out of your busy schedule here at San Antonio. For our listeners, we really hope that this discussion will be helpful to you in your clinical practice and has given you a little bit of a snapshot in terms of updates from recent meetings, and more to come. We expect more data in this space in the coming year or two, and it's going to be fast-paced, I expect, again, and practice changing, hopefully. And it's been a really exciting time to be a clinical investigator in the HER2-positive metastatic breast cancer space. And now we even see T-DXd moving into early breast cancer, both in the neoadjuvant and in the post-neoadjuvant setting for patients with non-pathologic complete responses after neoadjuvant. So more to come. Thank you very much for listening, and we look forward to giving you future updates.
Thank you.